Thanks for this invitation and opportunity to review evidence-based MRSA control and share experience from Taiwan. Since 1960, MRSA has emerged, disseminated globally, and become a leading cause of bacterial infection in both healthcare and community setting. The success of MRSA is a consequence of extended aerosol of various factors as well as beta-lactam resistance. Its clinical manifestation ranging from asymptomatic colonization, mild skin and soft tissue infection to familial invasive disease with high mortality. MRSA is a prototype of a subsequent series MDRO. Through this 30 minutes presentation, it is a good opportunity for us to look back regarding our experience in containing the pathogen. These experiences are very important for us to control COVID-19 as well. With your similar, SARS-CoV-2 can range from asymptomatic carrier to familial infection in otherwise healthy adults. MRSA prevalence vary by different geography, different country, as well as different household or patient population. This recent review demonstrates the data from a country. You can see the variation in its prevalence of MRSA as well as the time trend. Here we like to say congratulations on UK experience. Based on a recent paper, they showed there's a 97% reduction in MRSA bloodstream infection in UK ICU patients between 2007 and 2016, following implementation of National Infection Control campaign. Here I would like to share experience from Taiwan, Korea, and Japan. Why we choose these three countries? Because based on open access data and based on national surveillance report, we found only these three countries has continued annual data for up to 8 years. You can see over the 8-year periods, the healthcare associated infection rate decreased from 9.3 to 5.0 infection per 1,000 patient days in Taiwan, as well as a more than 60% decrease in the number of MRSA isolates in Taiwan. This figure demonstrates the action implemented in Taiwan since 1984, including surveillance, infection control program, acts and legislation. In 2007, we have a national program to promote hand hygiene. In the following years, we have sequential effort to promote care bundle, as well as environment hygiene program and antimicrobial stewardship. In recent years, we also revision of Infectious Disease Prevention Act on ICD, infection control doctor and infection control nurse staffing. This table summarizes common pathogens causing healthcare-associated infection in ICU in 3 countries in 2015 for bloodstream infection and pneumonia. Star RS ranked 4 in Taiwan, but higher ranking in Korea. Regarding Japan, we cannot compare Japan's data with the other country because the data in Taiwan are limited to centralized associated bloodstream infection and ventilator-associated infection. This is slightly different from Korea and Taiwan. Here is National Surveillance of Healthcare-Associated Infection in Taiwan, released by Taiwan CDC between 2011 and 2020. You can see the number of isolate and the proportion of MRSA from medical center as well as from regional hospital. The proportion of MRSA decreased gradually, and no significant difference between medical center or regional hospital. But based on the number of isolate, MRSA isolate decreased dramatically during this year. This is not an easy task based on our experience. You can see MRSA healthcare-associated infection rate in our hospital increased gradually since 1981. Parallel the infection rate of Star Oryx. We do a lot of effort. We call MRSA bundle, but later on extend to other MDRO, which includes surveillance, feedback, contact isolation, and outbreak investigation. At that time, surveillance are based on hard copy, manual method for analyze, and the feedback usually left for several weeks later. It's not real-time feedback. Although we do contact isolation, but we cannot afford single room isolation, usually by cohort or at the same bed, and healthcare worker wearing gown, mask, and gloves. During this year, we had outbreak investigation and identify our surgeon carry MRSA sharing this identical chrome with patient. But later on, we do some effort and the proportion decreased gradually. What effort? After SARS, we initiate and promote hand hygiene hospital-wide every year. And here we show the impact of the hand hygiene program. The green one are data before this program. The yellow one are predict data. The blue one are observed data regarding the hospital-wide healthcare-associated infection, ICU infection rate, infection due to MRSA, infection due to extended drug-resistant Acinetobacter baumannii. You can see the significant reduction of the infection rate. This is the changed level of changed trend. Although the disease severe score of the patient hospitalized during this year increased gradually, nevertheless, we are significant decrease in infection hospital-wide or due to MRSA. This right-hand side. This study also demonstrates implementation of this hand hygiene program reduce preventable healthcare-associated infection and is cost-effective with a benefit-cost ratio of 23.7. That means you invest $1 will take the saving for $23. Although at that time we promote alcohol hand rub, at that time it's relatively expensive comparing to conventional hand wash using antiseptic or soap and water. These days, the alcohol hand rub is much cheaper. The MDR bundle contact precaution, including hand hygiene, personal protective equipment, labeling equipment, patient empower, and environment cleaning. We ask for healthcare workers as well as caregivers to wear gloves, gown, and mask. We label at the entrance door and at the base side. The labeling, we also have a QR code to encourage patient and caregiver to learn how to protect themselves and prevent transmission to others. This is a label and to show that this is contact isolation. Here, the labeling will not disclose the patient information as well as what pathogen to protect patient privacy. However, we design the medical order in our portal system, that is health medical record computer system, will define contact precaution or for specific for MRSA, for VRE, and others. Physicians need to set up this order, then nurses or other healthcare workers in the same unit or in the examination room will recognize this patient require contact isolation. In order to improve the efficacy of surveillance and data feedback, we established a web-based MDR surveillance and outbreak detection system with rule-based classification and clustering. Through this effort, we can reallocate the manpower time from surveillance to intervention, and through PDCA to improve the infrastructure and more opportunity to conduct baseline audit. This pyramid demonstrates how we improve the infection control prevention measure at baseline using this system. MDR is a very good model for communication between infection control personnel and healthcare worker at the bedside. For example, every infection control personnel will review the line chart in this system to either hospital-wide or in specific unit to identify any unusual increase of the number of specific drug-resistant organisms such as MRSA. If any suspicion of clustering or increase of number, infection control nurse will notify the hospital unit to intensify prevention measure and visit the bedside to audit without announcement that whether they are compliant with hand hygiene or contact precaution, or check whether the environment cleaning is satisfied. If necessary, will conduct active microbial surveillance for patients and check the environment whether there is a reservoir contaminated and it's the optimal environment cleaning. If necessary, we will collect the isolate and conduct molecular epidemiology typing and report in the community. With the success of the MDRO IT system, we further extend the function to almost automatic screen and detect for patient fulfill the criteria of healthcare-associated breast infection. Through this IT system, we further improve the delay of the HABA site detection and the feedback, even during the pandemic or JCI. Therefore, we infection control personnel have more time to implement for systematic change. This picture showed a series of infection prevention programs conducted in our hospital, in addition to MDRO bundle, as well as hand hygiene promote after the SARS. We conduct a serious effort bundle care with our ICU colleagues, including BSI bundle, UTI bundle, VRT bundle, and with our surgeon, we work together to improve SSI bundle. Through this effort, part of the effort is to prevent transmission, some are prevent infection. This is despite the aforementioned effort and the success in control MRSA infection, we still frustrated regarding the high infection rate in patients with hematology malignancy. Therefore, we promote universal decolonization using chlorhexidine bathing. In this prospective control cohort study, we compare outcome of patients who choose chlorhexidine bathing with outcome on those who did not choose chlorhexidine bathing. We call usual care group. The primary outcome and the negative control outcome I will explain in the next slide. This study showed that the chlorhexidine bathing group has a crude incident rate of primary outcome that was 60% lower than the rate of the usual care group, but had similar crude incident rate of the negative control outcome. In multivariate analysis, chlorhexidine bathing, universal bathing, was associated with a 60% decrease in primary outcome. In contrast, chlorhexidine bathing had no effect on negative control outcome and well tolerated. What is primary outcome? Primary outcome means the first occurrence of healthcare-associated breast infection caused by common gram-positive cocci-related breast infection, such as the RS of group A strep, culture from at least one set of blood culture, or skin flora-related breast infection, or central line associated breast infection. What is the negative control outcome? This is the first occurrence of gut origin bacteremia, which was operatively defined as a healthcare associated with E. coli or Klebsiella pneumoniae bacteremia. These two most common enteric bacteria, which accounted for nearly all gut origin bacteremia at our hospital, that occurred after the start of cytotoxic chemotherapy. Why we designed this? Because in our previous hand hygiene program paper, we already demonstrated that hand hygiene program had no impact on the infection rate of E. coli and Klebsiella, as well as infection in hematology malignancy unit. Through this cytotoxic chlorhexidine test, you can see this is the left-hand side is a primary outcome. There's significant difference between the patient with adverse event comparing chlorhexidine and the usual care group. However, there's no difference regarding the negative control outcome. This study is very important, as you remember that the star RS in Taiwan is reinforced. Therefore, we have a significant proportion of infection due to gut flora, which are not preventable through a serious effort of conventional infection prevention and control measure. We take a look. This is from German expert. This systematic later analyze and review a targeted preventive measure to limit healthcare-associated infection by MRSA. I quotation their impression. Although the study report good evidence support the role of active surveillance followed by decolonization therapy, the effectiveness of single-room isolation was mostly shown in non-controlled study, which should inspire further research regarding this issue. Here demonstrate the difficulty in design high quality of the study to demonstrate the impact of this prevention measure. Overall, this review highlights that when planning the implementation of preventive intervention, there is a need to consider the prevalence of MRSA, the incidence of infection, and competing effect of standard control measure, that is hand hygiene, and the likelihood of transmission in the respective setting of implementation. Regarding the screening and decolonization, we have very limited screening effort designed for MRSA at present time. And we did not promote decolonization other than the chlorhexidine bathing in hematology unit, just because of very high infection rate despite the fully implement of other effort. However, this systematic review published in Nature Review Microbiology summarize a series of study regarding the impact of screening and decolonization. You can see the sample size very large, 1,000 or 10,000 patients, and many from United States, cover a different ICU, different patient population, using the universal screening, universal decolonization, or targeting isolation, using either mupirocin ointment or chlorhexidine bathing. The primary outcome including MRSA, surgical site infection, or bloodstream infection, MRSA infection, others. However, the impact on study outcome are very limited, either no effect or only reduced colonization, but not infection. All these studies are very, many are large scale and or multi-center. We put back to Taiwan data. This is provided by National Health Research Institute, demonstrate the MRSA prevalence in Taiwan based on TSR survey. This is a multi-center surveillance conducted every 2 years in Taiwan. You can see this data. In order to demonstrate that the healthcare-associated infection might be underestimated, the impact of MRSA. Therefore, this is based on microbiology surveillance. You can see the proportion of MRSA. The red line is ICU, decrease gradually and significantly. Less decrease was noted in general ward. However, the outpatient clinic and ER are relatively stable, but you can see the higher rate in ICU have decreased gradually after our national program, as I mentioned before. As I mentioned, that the variation of the MRSA prevalence might be due to the clonality change. Here is the data provided by NHRI in Taiwan. You can see the overall non-beta-lactam resistance in MRSA decrease, including erythromycin, genta, tetracycline, and trimethyl sulfate, except Cipro, are increased in recent years. The chronality, you can see the time change in major MRSA clone in Taiwan. Initially, in early years, the sequence type 239 is dominant in Taiwan, which is well known as a dominant healthcare associate clone. Compared to ST59 and USA 300 is dominant community onset clone. You can see the sequential decrease of these two dominant clones. However, more and more US 300 and others in Taiwan. The resistance profile of major MRSA clone are shown here. You can see the dominant healthcare associate clone ST239 are multi-drug resistant, and US 300 is Cipro resistant, but others are susceptible. This is might be the part of the reason why some of the resistance are getting better in recent years. Although MRSA prevention control intervention include limited emergent MRSA by judicious use of antimicrobial agent, control the reservoir, the carrier for high-risk patients during the high-risk procedure using targeting or universal decolonization, prevent MRSA transmission between patients, and reduce device and procedure-related healthcare associated infection. Because the MRSA is circulate in healthcare setting, community, as well as livestock. Therefore, one health approach is important. In addition, several measures are usually required to successfully prevent transmission and infection with MRSA. Therefore, we call MDRO bundle. Here, show the typical reason for failure of prevention control of drug-resistant organism. The reason might be vary by different household, different unit, or different group. Therefore, you need to recognize your own situation, and in order to develop or modify your program. In conclusion, we need to for MRSA control, we need to integrate surveillance and intervention. We cannot just spend our effort in just surveillance. This is document of your own failure. We need to tightly integrate surveillance and intervention. Surveillance provide opportunity to identify your own problem, understand your situation. Then we can prioritize our program, our policy to enhance safety and quality of care. The intervention including 3 tiers. This major need to decide based on the risk and the feasibility of each individual hospital or hospital unit. This including standard precaution. As we mentioned, hand hygiene alone has some impact. However, environment cleaning and others are important. If MRSA still increase, then we need to implement contact precaution as well. Otherwise, for very high-risk population or high-risk procedure, we need to consider either targeting or universal decolonization based on your resource or your situation. Based on our experience, we highly emphasize the ongoing effort should include antimicrobial stewardship and the patient empower. The data from Taiwan showed that all the effort can improve the reduce MRSA infection in ICU, but limited impact in general ward and no influence in the community setting. Therefore, patient empower, the implementations to outreach to outpatient and ancillary care setting. Next week is World Antimicrobial Awareness Week. I encourage every one of you work together to spread awareness and stop resistance altogether. Here, I would like to say thank you to my colleague from National Taiwan University Hospital, National Health Research Institute, Taiwan CDC, as well as Infection Control Society of Taiwan for their contribution in promote and implement infection prevention and control in Taiwan for research and for quality of care as well as patient safety. I also thank you our international collaborators from Korea and Japan. Thank you for your attention. Please stay safe and healthy in the context of COVID-19. Any comment or suggestion?